En este espacio, los protagonistas van a ser nuestros invitados de la IN, y en lo cual los invitados de la IN van a desarrollar los siguientes puntos: presentación institucional, experiencias en políticas de salud en Países Bajos, Francia y Luxemburgo, Suiza, Bélgica y África, y presentación de la calculadora de precios justos de medicamentos. En primer lugar, vamos a invitar a Loek Caubo, de Países Bajos, presidente de la IN, y a Sibyl Reicher, Bélgica, gerente general de la IN. Así que los invitamos. ¿Quieren
Okay. Does it work? Do you hear me? Yes. After what you hear now, I think we now have to go back to basics, because I have no floor show, I have no exciting presentation, but Cam asked us to give an overview about healthcare in Europe and several European countries. And that's what we are going to do now. I'm from the Netherlands, so I will start with a presentation about the Dutch healthcare system, and to introduce a little bit one of the problems for the work of AIM in Europe is that every country has its own system. They are all on a historical basis. There were made a lot of political choices in between. So it's very difficult to compare healthcare systems in Europe. And if you listen to what we are saying, then you can see that every system has its own advantages or disadvantages. So maybe if you listen and think about the future of healthcare in your country, pick the best things and try to combine them, I would say. Talking about the Netherlands. No, I have the other day. I speak in English, but they translated the presentation already for me, so that makes it a little bit easier for you to understand. In the Netherlands, until 2006, that's not on this slide, we had two healthcare systems in our country. And to define it quite simply, 70% of the people were insured for healthcare by mutuals. 30%, the richest part of the people, were insured by private insurance. And what was curious in that situation, the 30%, the richest people, paid less premium than the 70% that were assured by mutuals. And that was one of the reasons that government said, so we can't continue this way, so we have to re-invite our healthcare system, and from 2006 we have a new system. And this is a system I tried to explain. I said it's a hybrid system. It combines the role of mutuals as a kind of private organizations and public law. What we have in our country is that everybody in the Netherlands is obliged to have a health insurance. And this health insurance is delivered by our members, the mutuals, the mutual health insurers. Everybody has to pay a premium. Part of the cost are paid by premium, part of the costs are paid by taxes, and the healthcare is a package defined by government for essential care. And our members also offer complementary care, let's say for dentists and physiotherapists. More in detail, I try to explain several aspects. The first issue, universal healthcare. That means what I said, that everyone who lives or works in the Netherlands is obliged to have a health insurance offered by one of our members. And every year, the 1st of January, people can change. So every year you can change, you can pick your own health insurer if you don't like it anymore, or if you find a cheaper one. But this basic insurance is compulsory for everyone. The package of this insurance is defined by the government, and our members have to select everyone who wants to be an applicant for this insurance. That means if someone who has a bad health situation, or an elderly people, they are always also free to change of health insurance every year. So there is no risk selection at this point. Of course, solidarity is in the core of our health system. That means that everybody pays together for the health care of all, and all have the same rights in the health system. Our members, the mutuals, not-for-profit health insurers, offer this basic package, and they also offer, as I said, supplementary insurers for additional services. They have duty of care. That means that when you have an insurance at your health insurance, and you need a hospital or a doctor, then the mutual is responsible for the fact that you can go to a doctor. So they can't say you have to wait or there's no possibility. No, the insurer, the mutual, has to take care that you can go to the insurer. Very fundamental in our health system as such is that the GP in our country is gatekeeper. The emphasis in our system is on the primary care, and only when the GP thinks it's necessary, then you can go to a hospital or to a medical specialist. I go quickly through it, but there are more presentations. People think sometimes that we have a market-based system. In a way it is, but as I said, there are a lot of public guarantees by law. But what is the market aspect of our system is that mutuals negotiate with hospitals and with care deliverers about prices. And these negotiations must guarantee effectivity and low prices for healthcare. And while our members, those mutuals, are also in competition with each other, there's always a fight for the lowest premium and the best prices they can deliver. And like your country, of course, there is public regulation and public overview. On this slide, some figures, because your country is a big country, my country is a small country, but nevertheless we have 18 million inhabitants. I pick some figures. The cost per inhabitant on healthcare yearly are approximately 6,000 euros. But as I said, the costs are rising every year, and I found preparing this meeting that the annual increase of healthcare cost is 8% a year. So that makes it very complicated to maintain what we have. And the last slide I will show you makes clear what are the main challenges, and that is not only in our country, but that is in your country. The first place, a lot of diseases become chronic diseases, and that makes it possible to treat people for a long time, but that brings higher costs. We also have the increase of medical treatments and expensive medicines. We discussed it already, and Sibyl will say something about this in her next presentation. We have aging population, so in an increasing demand of care, but also we have a shortage of healthcare providers, of healthcare professionals. Maybe AI can help us a little bit in the future, as we listen to our previous speaker. And we have the economic situation and the uncertainty in the world. That together makes it very difficult to maintain healthcare as it is. And we discussed in several meetings these days, also with people in your country, that it is very important to think about the future, but also to involve people in responsibility, and one of the main policy goals in my country is that the present healthcare defines exactly what in the package is, what healthcare is available, but the question is this necessary for every patient in every situation? And one of the discussions we have now is that it will be in the future maybe more free and more specialized in for every patient to think what care is helpful for him or for her, and is this the best but also the most efficient way to deliver healthcare. This about the Netherlands. We continue with Sibyl about the pharmacy. Thank you.
So thank you very much. It's a great pleasure to be here. I speak English because it's easier for me to speak English. So I will present you actually what led AIM to develop a fair pricing calculator. So what is the European context? As you know, we have the European Union, but in reality, the European Union doesn't have the competence on the policy of health. It only has a competence with regard to industrial policy, economic policy, but it cannot influence how the countries organize their health systems. Only in case when there is a pandemic, the European Union can do some actions. So recently we had a revision of the pharmaceutical legislation. So the pharmaceutical legislation is for the pharmaceutical industry. However, we as not-for-profit solidarity-based health systems suffer from a commercial industry that is completely contrary to our own objectives, because the health system is not based on commercial objectives or conditions, but it's based on solidarity. So the Commission actually tried to find a balance between accessibility, innovation, affordability, and availability of medicine. So, and one recent publication was also due to the fact that more and more in Europe there's a lack of access to medicine and there's a shortage of medicines. And I don't know whether this is the case as well here, but we had, for example, last winter, German persons went over the border to the Netherlands to get syrups for the kids, because there was a lack of syrups for the kids, because there was like a lot of flus for kids, and then there was a lack of medicine. So the Commission proposed now what is called a Critical Medicines Act, and this is the background information I would like to give you. And AIM is actually acting on all of this. But what for us was very important is to act on the affordability of medicine in Europe, because what we see in all the countries, and it's really revelating that it's a global problem that the prices of medicines are rising so much. So, and this is a slide I took from a colleague of mine. She's Belgian, and she's actually the technical lead of our works on fair pricing. What you see is, and what you also saw in the slides that were presented this morning, that the prices of medicines, and especially innovative medicine, is rising tremendously. And this puts a lot of pressure on solidarity-based not-for-profit health systems. And I don't go into the detail. I don't know all the medication. I want to cite one example. A couple of years ago, there was a big discussion in Belgium. There was a medicine that was supposed to be very innovative for muscular dystrophy. It was called Zolgensma. And this was really a scandal, because it was 2.5 million to treat a kid that was very sick with muscular dystrophy, and the doctors among you know that this is like a deadly sickness. And so the health insurance fund, which was the Christian Mutuality, refused to pay 2.5 million because they said we don't have enough evidence whether this medicine is really helping, and from a solidarity point of view we cannot pay that. What the parents did is they made a crowdfunding, and they managed to get the money within 2 days. And then also the company that was producing this medicine said, okay, let's do a lottery. We give this medicine to 10 kids. And this is really so absurd and so paradoxical that the companies are playing with the health of a kid. And so it was really a big discussion in Belgium. And I think now Zolgensma is even not as effective as it was to be. So what we also see is, and that was also, I think in Dr. Pinetta's presentation, that the medicine is not as innovative as we think it is. So our German members, for example, they do every year, they do an overview how innovative is really medicine. And they note that not all the medicine that is on the market is as innovative as we would think it is. So why pay more for that? So we have been working on the theme or on the subject of fair pricing since the 1950s, since the very beginnings of the AIM. And then, as I said, there's a lot of pressure on the solidarity-based system. And what is more, we also want to have medicine that meet the unmet medical needs. So we want medicine that is really steered towards what do the patients need. So what is a fair price? We said, and there's a definition of the WHO, a fair price is accessible for health systems and patients, and it offers at the same time an incentive, a sufficient commercial incentive in order for the industry to invest in innovation and in the production of medicines. And that is the very paradox of medicine, because the pharmaceutical industry says, if you play on the prices, we don't have the money to invest anymore. So what we search with our work is equity for the seller and equity for the buyer and for the patient. So for the seller, we say that they should be able to cover their cost for research and development. For the patient, it needs to be accessible. Then for the vendor, it's important to cover the costs for the production and distribution, and as well the registration of the medicine, because that is also very expensive. And then for the patient, it is we have to link it to the benefits for the individual and the society as a whole. So we really look at, is it improving the life of the patient, but is it also bearable for the society as a whole? And then the last one is, because we are acting in a commercial environment, the industry wants to make some money. And for the patient, it's important that he has, the treatments are secure. So we were thinking about a model. What do we need to add to such a model? And we thought that it's important to look at the costs on the one hand, but also on the value for the patient on the other. So what we did is we looked at, and this is scientifically proven, we looked at the costs of research and development. If the research and development, if there's transparency, and that's a big problem because the pharmaceutical industry says that we cannot say or we cannot tell about our research and development costs. First, they seem not to know it, then they have a lot of medicine that is researched and will never make it to the market. And the third thing is that they say they don't want to publish their secrets, because if they publish, it would be openly known what actually they are investigating in. Then we looked at the costs for production and the general costs. And then we said also we need to look at the costs for the commercial information. And we said not marketing on a purpose, because we don't think that we need marketing for medicine. Because if a medicine is good, we don't need marketing. A doctor will know what is a good medicine for his people. And then, as I said, we need a basic profit. And what is really the most important element is the bonus for innovation. So we look, is the medicine really improving the life of the patient, the quality of the life? Is it prolonging the life? Will the patient live longer in a better health? And like the highest bonus, this is up to 40%, will be if somebody survives and has a good life after that. And that will bring us to a fair price at European level. What you also said is, what we see in Europe a lot is that some countries don't even have access to innovative cancer medicine, for example. So we said that because the pharmaceutical industry says it's not interesting enough, the market is too small for us. So what we said is that we could like link the fair price to the, how do you call it, a GDP of the country. So the richer the country is, the higher will be the cost for the medicine. Also to make it more attractive for the pharmaceutical industry. So our principles are that if there is a lack of transparency on R&D, we will put a cap, okay? And then we have in the whole algorithm, we have cost element and value elements, as I said. So we have done a lot of action since we introduced the fair pricing calculator. That was in 2021. And so one of a member of our members has done a study. They have taken 7 innovative medicines and they made a study for Germany alone. And what they found out is that if the fair pricing calculator would be used, and I recall there would be a profit for the pharmaceutical industry. For Germany alone, the German health system could save 13 billion euros, which is really a lot. Okay? The second thing is we have published some articles also in a scientific journal. Our member in Belgium has done actually a campaign, and they managed to have a resolution in the parliament in Belgium. Then also the European Commission has decided to provide funding for a European Horizon Europe project, and the basis for that is our fair pricing calculator. The project runs until next year, and the idea is to develop fair pricing or a model for pricing for the pharmaceutical, for medicines. And then we are also a member of the platform of the WHO on novel medicines. And then one last thing I wanted to say is we are currently in the process of finalizing an internal studies with 6 countries where we look at the fair prices for medicine, and we will publish it in a scientific journal, hopefully towards the end of the year. And this is the end. Thank you very much.
Invitamos a Yannick Lucas de Francia, quien es vicepresidente de AIN, a cargo de la colaboración internacional.
Est-ce que vous m'entendez? Oui, ça marche. Spanish. Señoras y señores, queridos amigos mutualistas. Como homenaje a la lengua española, que era la lengua en la que mis padres se hablaban cuando no querían que sus hijos le entendieran, voy a intentar hablar en español. Hoy voy a hablarles sobre las mutuales de salud en Francia, Mutuelle Santé, y los desafíos a los que se enfrentan actualmente. ¿Qué hacen las mutuales de salud? Es lo mismo. En Francia el sistema de salud se basa en dos niveles. La seguridad social, que cubre una parte de los gastos médicos, alrededor del 70% en general, y las mutuales de salud, que son organizaciones sin fines de lucro, como en Argentina, que complementan los recursos del Estado. Estas mutuas permiten que los ciudadanos tengan una cobertura más completa para consultas médicas, medicamentos, hospitalizaciones, óptica y dental. Las mutuas no son los únicos organismos que ofrecen servicios de seguro de enfermedad, pero aseguran a unos 35 millones de personas en Francia. Las mutuas también gestionan más de 3.000 establecimientos y servicios sanitarios. El funcionamiento de las mutuas es más simple. Las asegurados pagan una cotización mensual. El monto depende del nivel de cobertura. No seleccionan a los asegurados por edad ni por estado de salud. Esto es lo que llamamos los principios mutualistas, basados en el concepto de solidaridad. Los desafíos actuales. Las mutuas de salud francesas enfrentan varios desafíos importantes que son similares en muchos países. Primero, el aumento de los costos sanitarios. El envejecimiento de la población aumenta la demanda de cuidados médicos. Las tecnologías médicas son más avanzadas, pero también más caras. En segundo lugar, la presión económica. Las cotizaciones aumentan cada año. Los ciudadanos con bajos ingresos tienen dificultades para pagar una buena mutua. En tercer lugar, las reformas del sistema de salud que tienen por efecto aumentar los gastos reembolsados por las mutuas. Por ejemplo, el Estado impone nuevas regulaciones como la reforma del 100% santé, 100% salud, que obliga a las mutuas a cubrir totalmente ciertos tratamientos, gafas, prótesis dentales o audífonos. Esto genera tensiones financieras en una coyuntura económica en la que el poder adquisitivo de los hogares disminuye. Por último, la competencia y la digitalización. Nuevas empresas tecnológicas, InsurTech, proponen soluciones más digitales y personalizadas que atraen a los jóvenes, que son los buenos riesgos en materia de seguros sanitarios. Las mutuas tradicionales deben adaptarse rápidamente. En conclusión, yo diría que las mutuas de salud son un pilar fundamental del sistema sanitario francés, pero sin embargo necesitan modernizarse, gestionar mejor los costos y garantizar la solidaridad para poder seguir cumpliendo su misión social en un contexto cambiante. Gracias por su atención.
Ahora es el turno de Verena Noll, de Suiza, quien es vicepresidenta de AIM para la región de Europa. Toma, a ver, ¿quieres sentarte o quieres? Paso el otro lado.
Hello everybody, I hope that you hear me. I think so. Seems so. My name is Verena Nold and I am the CEO of Santé Suisse, the Association of Health Swiss Insurance Companies, which in your country means mutuals. Today I will share with you how the healthcare system in Switzerland works. We will look at how it is organized, what it costs and what makes it unique. Let's begin with some key facts. Switzerland spends around 94 billion Swiss francs, which means 117 billion US dollar, more or less, every year on healthcare. This is about 11.7% of the country's total economic output, the GDP. About 1/3 of healthcare expenditures are related to basic health insurance. The healthcare sector employs more than 500,000 people, including doctors, nurses, and staff employed in hospitals and nursing homes, as well as nurses supporting medical care at home. There are 37 health insurance companies with around 500,000 employees. Every person living in Switzerland, that's about 1.9 million people, also a small country, a bit smaller than the Netherlands, must have basic health insurance. Switzerland as a country has 4 official languages and is formed by 26 cantons. Cantons, it's like provincias, I think, in your country. It's more or less the same system, very federal system. The cantons enjoy a certain autonomy, how they regulate their health system. Likewise, the cultural difference between the French and Italian-speaking parts compared to the German-speaking part can be considerable. So we have more Latin culture in the south and the west side of the country, and a more German culture in the north of our country. In Switzerland, health insurance is mandatory. Every staying for longer than 3 months in Switzerland ought to be insured. The basic insurance covers 3 main areas: accident, if there is no other insurance. If you are employed, you are covered by the accident insurance of your employer. Maternity care and illness that need medical attention. The basic coverage is the same for everyone, and regardless of the insurance provider you choose among the 37 currently offering their services. The basic insurance is regulated by a law called the Health Insurance Act, or KVG in German. Everyone is required by this law to be insured. Insurance companies are not allowed to make a profit on it. Annual benefits must remain at the insurance company to bolster the reserves. Premiums are the same for everyone at a given insurer within a defined region or canton. In the east of Switzerland, for example, you pay less than in the north of the country. In the cities, you pay more than in small countries or in small villages. There is also a system to balance the risks between insurers in order to mitigate the phenomenon of chasing the good risks. People with low income get premium discounts. Prices for services are set using fixed rules for doctors and for hospitals by negotiations between these stakeholders. The prices for medications are set by the Federal Office of Public Health. Therefore, they are very high in Switzerland as well as in Germany and other European countries. The scope of medical treatments, medications, and other medical services that have to be covered and reimbursed by the basic insurers are identical for all insurance companies. This means everyone receives equal treatment, no matter which company they choose. There are no exclusions for people with pre-existing conditions. People can change their insurer freely and frequently. Every year, the 1st of January, you can change your insurance. The system is regulated by law and it's mandatory for all residents. Everyone gets the same basic coverage. If an individual has the desire and the financial means, there are supplementary insurance plans available, such as more room comfort in the hospital or coverage of a wide range of complementary medical treatments. The chart shows how the cost of health insurance has grown over time and will likely continue to rise. We have the same problem as the Dutch country as well. The index starts in 1996 at 100 and increases steadily. By 2030, the costs are expected to be more than double. This is a challenge for the whole system and it affects all of us living in Switzerland. In its report of 2024, the World Health Organization looked at Switzerland's healthcare system. It says it works well and is efficient, but they also say it's expensive. Switzerland has quite many hospitals compared to other countries, and that adds to the cost. The political system and the inclusion of the main stakeholders in tariff organization and reforms makes the system complex and a challenge to reform. Experts say that the country needs better tools to check if treatments are cost-effective. High costs do not always mean high quality. With the prospect of continuing cost increases, Switzerland must make sure it offers good value for the money spent. Thank you very much for your attention.
Invitamos a Abdelaziz Alaoui de Marruecos, vicepresidente de la IN para la región de África y Oriente Medio.
Muchas gracias, amigo. I'm going to speak English. Don't wait another language. Yeah. Do you hear me? Yeah? Oh, okay. Dear colleagues, mutualists, thank you for welcoming us to Argentina, a country whose 19th century pioneers proved that citizens can pool risk and protect one another long before universal social security. You had mutuals before you had constitution. Your journey mirrors that is unfolding today across Africa and Middle East, where in 54 nations, 10 of millions of women and men are turning to mutual health organizations because when the public purse in them and commercial premium are prohibitive, solidarity remains the most affordable currency. AIM has declared 2025 the year of solidarity. Never has the principle been more urgent. What kind of world are we living in when 2 decades into the 21st century, we still have to fight for a basic right as fundamental as health care? The answer, of course, is a world that needs more solidarity, not less, a world in which mutuals turn rights on paper into medicines in the clinic, premiums into protection, and neighbors into partners in one another's well-being. Less than 15% of Africans currently benefit from formal health insurance, and most work in the informal economy where out-of-pocket payment can be catastrophic. Mutuals close that gap. They collect modest community-based contribution and negotiate fair prices with providers. Yet they still need an enabling environment, technical know-how, and political recognition. That is where AIM comes in. This transformation has been reinforced by sustained investment in human and technical resources. It has also been communicated to the target population as well as to all stakeholders involved in the healthcare process. And to bring services even closer to its user, Morocco has relied on digitalization and new technologies to reduce costs, distances, and delays. Finally, this progress could not be conceived without a comprehensive reform of the healthcare system to best meet the growing demand for care and to meet internationally recognized quality standards. Africa wrote the Lomé platform, a 21-point plan that calls on governments to recognize mutuals in law, make enrollment progressively mandatory, and delegate parts of universal health coverage to not-profit schemes. It remains our compass for advocacy from Dakar to Dar es Salaam. In 2022, 40 federations adopted the Dakar Declaration, recommitting to Lomé's goals and speaking with one voice to African Union and the United Nations. This February, in Burundi, AIM co-organized the Bujumbura International Mutualist Conference. 200 delegates from 24 countries assessed progress, agreed on pooled procurement for medicine, and urged government to write mutuals health coverage explicitly into UHC legislation. Those catering matter. They provide the legitimacy national movements can quote when negotiating with their ministers of health. For anyone new to mutualism, Morocco's healthcare reform offers a powerful red-word example of what solidarity economics looks like when scaled nationally. It is a model that brings to life the foundational principle of mutualism. We all contribute according to our means, so we all receive according to our needs. Morocco's transformation is not theoretical, it's practical, ambitious, and already delivering results. Until recently, the country operated with two separate health systems. The AMO scheme provided insurance for salaried workers through payrolls deduction with RAMED, a government subsidized program, offered more limited care for low-income citizens. These two systems reflected the divide between formal and informal employment and inevitably a gap in the quality of care received. That changed in 2022 when Morocco undertook a bold reform. It merged both systems into a single national health platform called AMO Tadamun, Tadamun meaning solidarity in Arabic. This change was made possible thanks to the royal vision which encouraged politicians to implement this social project with the establishment of roadmaps and legislation to legitimize it. Because without political involvement, solidarity cannot take place. The move transferred 11 million previously undercovered people from RAMED into the full benefits package of AMO, effectively ending the two-tier system and creating Africa's first unified national health system grounded in mutualist principles. This transformation has been reinforced by sustained investment in human and technical resources. It has also been communicated to the target population as well as to all stakeholders involved in the healthcare process. And to bring services even closer to its users, Morocco has relied on digitalization and new technologies to reduce costs, distances, and delays. Finally, this progress could not be conceived without comprehensive reform of the healthcare system to best meet the growing demand for care and to meet internationally recognized quality standards. In doing so, Morocco has demonstrated that mutual health systems are not only for high-income countries or small cooperatives. They can be built and sustained in middle-income contexts and scaled nationally. The model challenges the idea that free healthcare is the only path to universal coverage. Instead, it shows the strength of systems where responsibility is shared and benefits are equal. Dear colleagues, next step on our journey as mutualists: complete the legal puzzle, guarantee medicine affordability, scale digital inclusion, invest in people, celebrate solidarity. Solidarity is not a slogan, it is an infrastructure, a law passed, a premium collected, a claim reimbursed, a child treated in time. Every line I have dictated is a brick in that structure, but bricks needs mortar, and the mortar in the trust we build when continents collaborate. Colleagues, let us keep laying bricks together so that whether you are a farmer in Casablanca, a teacher in Cordoba, or a street vendor in Dakar, you can count on a mutual to protect your health, your income, and your dignity. Muchas gracias. Merci. Shukran.
Invitamos a Fabio Secchi, de Luxemburgo, quien es CEO y presidente del Comité Directivo de la Caja Médica Complementaria Mutualista.
Estimadas y estimados, es un honor dirigirme a ustedes hoy como director general de CMCM. En un momento de grandes desafíos económicos y sociales, la solidaridad en los sistemas de salud y pensiones es más importante que nunca. Nuestra misión es garantizar que cada ciudadano tenga acceso a una atención médica de calidad y a una jubilación digna basada en los principios de inclusión y equidad. Sin embargo, ahora cambiaré al inglés. Como soy mitad italiano, entiendo y hablo un poco de español, pero no lo suficiente como para continuar todo el discurso en este idioma. Espero que me lo perdonen. Let me start with the first pillar of the Luxembourgish health system, the national health coverage by the Luxembourgish state. It is a mandatory health insurance run by the state. The Caisse Nationale de Santé, CNS, of Luxembourg is the organization responsible for managing health and maternity insurance as well as long-term care insurance. It covers healthcare services, pays out benefits, monitors the quality of services provided, and informs both insured individuals and healthcare professionals. The Caisse Nationale de Santé is facing a deepening financial crisis. In 2024, the CNS recorded an annual deficit of nearly 26 million euros, and this is projected to surge to 133 million in 2025, representing 16.5% of annual expenditure. The causes are structural: rising administrative costs, a lack of consensus among stakeholders, and delayed reforms, including outpatient care and cost containment strategies. This level of deficit threatens the very stability of the system. The Credipartite Committee has acknowledged the urgency of the situation, and the Ministry of Health has promised a comprehensive reform package by autumn 2025. If no corrective measures are taken, CNS's reserves could fall below the legal minimum by 2027. The term Quadripartite Luxembourg refers to the Quadripartite Committee, a consultative and coordination body in the field of healthcare. It involves the government, employer organizations, employee organizations, and healthcare providers. This committee reviews the financial situation of the health and maternity insurance system and proposes measures to improve its efficiency. On the other hand, the Luxembourg Association of Doctors and Dentists has warned that without constructive dialogue, the crisis will become purely political. They rightly argue that shifting the burden to doctors and patients is not a solution, it is a symptom of failed governance. I will continue with the second pillar, which is the Centre commun de la sécurité sociale. It is the social security institution whose responsibilities include the registration of insured individuals, as well as the calculation, collection, and recovery of social security contributions. This institution continues to provide generous pensions, but demographic trends are straining its long-term sustainability. As of May 2025, the minimum personal pension in Luxembourg is 2,350 euros per month, which is 3,500,000 pesos. The maximum personal pension is 10,800 euros a month, which is 16 million pesos. And the annual pension is adjusted every year by about 1.6%. These figures reflect Luxembourg's commitment to retirees. But with longer life expectancy and fewer contributors, we must explore complementary pension models. And these models should be introduced and governed out of a mutualist perspective rather than commercial insurers, and ensure intergenerational fairness. Now I'll tell you some numbers about the income landscape, the salaries and contributions. Luxembourg's income levels, as you may know, remain among the highest in Europe and even in the world. The average gross monthly salary amounts to 5,500 euros, which is 8.2 million pesos. The median income is 3.5 thousand, which is 5 million pesos. The minimum wage, so the minimum you get when you have a paid work, is 2.6 thousand euros a month, which is 4 million pesos. And the minimum wage, if you are a skilled worker, is 3,000, which is 4.7 million pesos. These salaries fund our social systems, but they also highlight the risk. If public coverage weakens, only the wealthy will be able to afford private commercial alternatives. So now to CMCM and the role of mutual societies. CMCM is one of 33 mutuals, but it is the only representative one and the only one that offers a lot of health coverage in addition to the national health insurance. In this context, mutual societies like CMCM are more important than ever. Some recent numbers about CMCM. We serve 280,000 members out of 600,000 people living in Luxembourg. So nearly half of the population is a member within CMCM. We process 200,000 claims and we pay out over 71 million in benefits in addition to the national health coverage, which is 105 billion pesos. And we reinvest 3.5 million of our excedent every year into new services. We offer no medical exclusions, no extra fees for family members, and an enhanced coverage for psychological care, dental implants, and orthopedic support. We are proud to be a non-profit, solidarity-based organization, and we are accelerating our digital-first transformation to better serve our members. Now to the threat of the commercial insurers. In Luxembourg, and moreover across Europe, commercial insurers are increasingly undermining mutual health funds. Their strategy is clear: promote selective coverage, target high-income individuals, and lobby against mutual protections at national and European levels. This trend threatens the very foundation of solidarity. If mutuals are weakened, citizens will be forced to seek additional coverage from commercial providers, coverage that only the wealthy can afford. The European Insurance and Occupational Pensions Authority has noted that insurers act as contrarian traders, stabilizing markets only when financially strong. In times of systemic stress, their support vanishes. We must not allow our healthcare systems to become a luxury product for the wealthy people. We must not let solidarity be replaced by segmentation. And therefore, here's my call to action. Mutual societies must unite. We must advocate for legal protections at the European level and specific laws for mutuals acting on a strict non-for-profit level. Recognition of mutuals as essential pillars of social protection and fair competition rules that prevent commercial insurers from eroding public trust. Let us reaffirm our commitment to solidarity, not just as a principle, but as a practice. Let us innovate, not out of necessity, but out of responsibility. And let us ensure that every person, regardless of income, can count on a system that protects them and enables the same medical cures for all. Les agradezco su atención y les deseo a ustedes y a todos nosotros un futuro fuerte y resiliente para nuestra causa mutualista y nuestras mutualidades basadas en la solidaridad. Muchas gracias.